Good morning, students. My name is Kelly. I've met many of you before. I'm here today working with Professor, Professor Nicola in your women's health rotation, and I have specifically put together a PowerPoint on the newborn. And my approach today with you is to present this like you are new nurses who have been hired in the mother baby unit, and I'm giving you kind of just a training on what to expect. And I'm going to talk to you like you are the nurse and what your role and responsibilities will be, and give you just some background and understanding of stuff that you might see on the mother baby unit as a new nurse. So first off, what makes this unit unique and different from any other unit in the hospital is so the ratio is 4 to 1. That means 4 rooms to 1 nurse, but it's not 4 patients, it's actually 8 patients. So as a mother baby nurse, they're called couplets. You have a mom and a brand new baby in every single room that you are responsible for assessing and monitoring throughout your shift. So you are doing double pretty much of everything for every room, and you have 8 patients that you want to care for and make sure are well, and all the proper testing and everything is done within the right time frame on your shift. So with that, I'll go ahead and begin. I went ahead and I hope you guys enjoy the pictures too. I got some really cute pictures of babies, which makes this even more fun. I'm going to start with just letting you know what to expect in this presentation and what the objectives are. So it's a big deal, for a baby to come from being in utero and completely um, uh, relying on mom for everything. They're together as one, and then suddenly on your watch you have this new transition where the baby is now on his or her own, and things are different for the mom too, because she shared everything with this baby, and now that the baby is out, there are as you can imagine, major hormone shifts and changes within her body to basically come back and be one person as opposed to two. This lecture is, we are focusing on just the baby though. So I mentioned earlier that this is an orientation. You are a mother baby nurse. This particular teaching is focusing on just the newborn. So we'll start with what to expect in that transition from being with mom to out. So that's the intrauterine to extrauterine life. It's really important also to understand the approximate gestational age of the baby, because we would expect different physical and um, outward and inward differences when you are assessing a baby based on the gestational age. So I will go through that and kind of give you cues to let you know what you might expect on babies based on their gestational age. And then there's all sorts of, I will go through slides about classifying the newborn in all different ways. And I have the standard classification that I've included for you in this PowerPoint. APGAR scores, you've heard of those. We'll talk briefly about how that's assessed. That actually happens in most hospitals. The way it's set up is you have the labor and delivery nurses, which are typically in a different area or even a different floor. Then after the baby is born and stable, the baby and the mom are transferred to the mother baby unit. As far as the newborn nursing, typically on the labor and delivery floor, there will be some sort of nursery nurse, so there's different names for it, where that nurse is responsible for actually being in the delivery and doing an immediate assessment of the baby, which includes the APGAR score. So very often in the hospital, that nurse will kind of be bouncing around and gets to see all these deliveries and assess the babies, where then there's a different department, the NICU. So that's where the baby would go if the baby was any kind of distress and an unstable infant. And those are specialized nurses who are trained and who daily care for babies who are considered unstable. Then you go to the baby, like I said, the normal transition would go to the mother baby unit. That nurse would have her 4 couplets. And then in many hospitals, there's also a newborn nursery for stable babies. And that nurse, who also specializes in just the newborn or maybe just acts as a resource nurse and helps the mother baby nurses, will do the testing and assessment, and which we will go through, of stable babies on that floor. Now, in many hospitals, there's not such a thing. There's not a stable baby newborn nurse, and that those all fall on the responsibilities of the mother baby nurse. So just to kind of give you an understanding of when I will try to be clear who would be the primary caregiver at a particular situation for a newborn and where the assessments take place. So again, the APGAR score is up on the labor and delivery floor, and it would be a nurse who would immediately assess the baby and determine whether or not they're stable. And a lot of that is related to the APGAR score. Growth measurements we will go through in all parts of the body and when those take place and why that's important for a newborn to measure and weigh and assess every single part of every system. Vital signs, I'll talk to you about how we do that and why that's important, the different systems, the ability to recognize what would be considered normal and stable in a newborn and what would be maybe a call to the pediatrician or the neonatologist, or an immediate transfer to NICU. So, which again is for the babies who are considered unstable. And then lastly, just the ability to recognize things that are very common for newborns that may be problems or maybe something that we just continue to assess and we note and we're aware of. And there are many situations with a newborn where we'll see something, we'll note it, and it will just resolve on its own. Okay, let's move on. So briefly, I wanted to touch on, and your textbook does this, we talked about how it's a major change for the baby when going from in utero to all of a sudden being in the world, and their systems, most notably, the most important one is the lungs, right? Because before the baby's born, the baby gets all their nutrients and their exchange through the placenta, and probably you guys know this by now. So the baby is delivered, and then shortly after it's another delivery, and you'll see the umbilical cord that is attached to the placenta, which provides everything for the baby in utero. So once the baby's out, this is a big thing with why a vaginal delivery is helpful, because it kind of like compresses the baby and gets in the chest and pushes the fluid out, which makes it a natural and often easy for the baby's lungs to inflate and fill with air, and they take their first breath and we get to hear the first cry. So again, when the baby's in utero, there's not air in the lungs, the babies aren't breathing through the lungs, and then pretty quickly, often within 30 seconds after birth, and with touching the baby and clamping the cord, these things that happen initiates breathing, and suddenly the baby makes this amazing transformation and is breathing air. So circulatory function as well is very different. The big thing is to clamp that cord, and that initiates a lot of these changes, because then the cord can't rely on the placenta anymore, and the baby's out in this external world and quickly doing things on his or her own. And these are the inside of the baby in the heart. These are those patent, the ductus arteriosus and foramen ovale and ductus venosus, which are moving and patent. They close off as part of the transition into the baby actually using their lungs and doing things on their own. So just a general understanding of how this works and how this might contribute to normal and abnormal findings in the newborn is good for you guys to understand. Okay. So there are different periods that we expect with the newborn in that transition. And there's this period that is actually called the transition period. And this is the newborn changes that take place right after the baby's born. Like I said before, so we expect the newborn to be stable within 1 to 2 hours, and very typically the baby is still on the labor and delivery floor with mom until they become stable. So when you're on the mother baby unit, the baby is typically at least 2 hours old, and they have gone through this initial transition period. And reiterating what we saw earlier, that the big deal is to clamp the umbilical cord, and you can see it right here. This is very normal. Umbilical cords do come in different shapes and sizes, and the important thing is to be able to recognize that there's 3 vessels, and it looks really wet like this when you would first get the baby on the mother baby unit, and then this clamp is here, and we just basically we leave it alone. We don't put any alcohol or anything on it, which kind of grandparents you might teaching to patients is, oh, your parents might say, oh, we put alcohol in this to make it dry. First of all, we would never do that in the hospital, and then that's something that they might do, or their parents might tell them they did it. Once we take off this little clamp and it's kind of just a little stump, we teach the patients to just let it dry and fall off itself. And I'll get into later about bathing the newborn. And so we really want to keep it as dry as possible because that just helps encourage it to fall off. And this little clamp here, a mother baby nurse, before discharge, we have these little like special tools that it's just a little plastic piece that kind of fits in this little circle right here. And then you make a cut. You don't cut the baby at all. You cut it and then it kind of opens up and we take this off. And very often the parents will, I know I did with my kids. It's just kind of, they keep this kind of as a souvenir and it goes in the baby's baby book. So you want to make sure you don't throw that away and you at least offer it to the parents to take this little clamp with them. So I'll go through this in detail shortly, but many of these first assessments now, the trend is that we keep the baby with the mom as much as possible. And if the baby is stable, these initial assessments during this transition period can almost all take place while the baby's skin to skin in mom's arms. Okay. So this is just a very basic, gives you some definitions of newborn terms. So a baby is considered a neonate in the first month, approximately 28 days of birth. And so when you're reading information, whether you are in your textbook or materials that we provide to mom to take home, the baby is referred to as a neonate within the first month of life. Then it's important to understand, like I said, when we're making assessments, you will see in the chart uh, denoting whether or not the baby is considered preterm. And that means that, so full term, I'm pretty sure you all know now, it's 40 weeks. Preterm is considered less than 37 weeks of gestation. So that's the baby is less than 37 weeks old before they come out into the world. Term is 40 weeks is normal, and term is considered anywhere within normal is 38 to 42 weeks. And then it's important to know post-term too. Now, it's very rare these days that babies are kept in this long. So you're likely not going to see a baby in the hospital who is a gestational age of more than 42 weeks, because then complications start arising there too. And I'll show you some pictures in here where you can kind of assess, and pretty quickly, just by eyeballing a baby, you can make predictions on what their gestational age is. And then the other big thing that you'll see in the charts is this AGA, SGA, or LGA, and that is referring, the GA is gestational age, so it would be average for gestational age, or small, or large. And this shows the percentiles of the baby based on their weight. So everything, when we are assessing these sorts of things, this chart that I have here at the right, these are the weeks gestation that I just mentioned. And then you look over and you see what would be expected for the weight. And everything's done in grams in the hospital. And so you would translate this oftentimes when you're weighing the baby, and we weigh the newborn daily, typically on the night shift. And when the grams come out and we chart that, we would transfer that into pounds for the parents, because obviously, and all you do is you just press a button and it does it for you, because the parents aren't going to understand the grams. And then also we'll talk about how it's very normal for the neonate to lose weight at first, and we have certain criteria about what is expected and considered normal and what isn't. And so you, as a mother baby nurse, when you're bringing that scale in and you're weighing the baby, and they go, oh my gosh, my baby's lost weight, you will be able to teach them, first of all, that we expect that and it's normal, and then what's considered within normal limits. And I'll go through that in detail a little bit later in the PowerPoint. So here's a picture for you. And I went ahead and just translated it into pounds. And you can kind of see the babies look very different because you think about 3 or 4 pounds for us, our friends may not notice. It won't really affect the way we look. But when you're talking percentage of body weight, you can clearly see that this little guy who's 5.5 pounds looks very different from the LGA baby here at the right, who is 9.5 pounds. And we will go through in detail what you can notice here. But just at first glance, I'm sure that you can appreciate that an SGA baby presents very different than an LGA baby. So I'm going to try to be clear with you guys as I go through this presentation too. The abbreviations or the newborn terms that are used all the time and that you really need to commit to memory. And then some of them that you could just, like most nurses, we still have to sometimes look up stuff. And so the terminology that you won't see and that you will see a lot. So this SGA, LGA, AGA, you need to commit to memory because that's how they talk in the hospital and with all the charting, and you need to know what that means. Okay. So I love this slide. Okay, the baby's born, now what do we do? And this is a big thing when you get to be a new nurse and talk about all of these fabulous, amazing changes that take place with the baby being born. This slide right here is just kind of a quick synopsis for you. It's a very quick drying of the infant, which that in itself stimulates the infant to breathe and to get sort of, hey, you're in the real world now, and it's like kind of gets things to start. It also is important because babies get cold, and we'll go through that. And so we want the baby to be completely dry because in the process of drying on its own, that's cooling, and we don't want the baby to be cold. We worry about babies being too cold. There may be a very quick clearing of the airway of secretions, and they would just use a bulb syringe, which is just one of those green things that in part of your patient teaching too, it kind of, I don't have a picture of it here, but hopefully you guys know what I mean. It's sort of has a circle on the end and then kind of a long pointy side. And often when babies are older or even toddlers at home, moms, when a baby gets a cold or something, well, when they can't quite know how to blow their nose, they'll put that at mom's or dad's, and you kind of press it first and it takes the mucus out of the nose. Part of our teaching in the hospital is a brand new baby's little nose is way too small and you can cause damage. And even though we have those at the hospital for the baby, that is always needs to be there, and that's for emergency. That'd be an emergency more if you thought the baby might aspirate, the baby's choking on. It could just be amniotic fluid at first. It could be the colostrum from the mom or formula if they're feeding. And that little, this is the same one that they clear the airway of secretions when the baby's born. But on the mother baby unit, we would teach the parents to turn the baby to the side. You never put it straight down the baby's throat, but the teaching would include you press it first, you put it over in the side of the baby's mouth, and you gently pull it out. And that just removes the fluids, which you lift the baby and you don't want the baby on their back when they're doing that. So you sort of get them in your arms, you have them upright, and it removes the fluids so they to take away that risk of aspiration or choking. And then the last one, which I mentioned, is to provide warmth. And the absolute best, perfect warmth for a baby is skin to skin with mom. And I show you in this picture here. So we would, sometimes they don't even put a diaper on the baby, but in our facility, we would put a diaper on the baby. That's it, no other clothes. Put baby skin to skin with mom, and then you could have a newborn blanket on top of the baby, or you could bring up mom's blanket and just kind of have the outside of them covered, but mom's typically really warm and baby getting as much possible as exposed. You would turn the baby with the whole abdomen as much skin to skin with mom, and that's just wonderful and perfect. And the first intervention to sort of stabilize the baby. So there's a quick assessment here. We talked about gestational age, and this indicates whether or not we don't have to do anything, any major interventions for the baby. We want to know if the baby's gestational age is greater than or equal to 35 weeks. Does the baby look good? Is the baby floppy, or does the baby have good muscle tone? And I'll go into that in more detail later, but that's very quick and easy to see. And obviously, is the baby breathing and or crying? The baby doesn't have to be crying, but that is a good indication that things are moving and the baby is breathing. So those three questions are asked, very simple, quick. If all answers are yes, then you put that baby right on the mom. While the baby is skin to skin is when is it best to perform these APGARs that I talked about. And the next slide talks about in detail the APGAR score. 1 minute after the baby comes into the world, we do the first one. Then the nurse, this is typically um, that newborn nurse who is probably going from room to room and not really staying with the baby, but is performing these initial assessments. She would be the one who is performing this APGAR and calling out the score to the doctor. So that's within 1 and 5 minutes. And then while the baby is up on typically the L&D unit with the mom, the temperature is Q30. So every 30 minutes, that nurse who is typically going from room to room needs to have a timer and know that, hey, I got to check back on my babies within 30 minutes, assess their temperature. And then once the baby, this is until 2 hours of age. And then once the baby becomes stable, then depending on different criteria, it's typically Q4 when you are assessing the vital signs. But right away, it's every 30 minutes. Okay. This is the APGAR scoring. And again, I'm talking to you guys. You guys are new nurses. You will, because in reality, you're still being tested, need to know this APGAR scoring. But even as new nurses, it's important to understand what this means, whether you are the one actually doing the assessment or you're the nurse on mother baby, because in report, they will let you know what the APGAR scores are for the baby. And it's important for you to understand and be able to predict problems that may occur later based on their initial APGAR scores. So this is the chart. Each of these 5 areas is assigned a score from 0 to 2. I like this little chart with the blue and the pink here. There's different ones in your textbook and elsewhere, but it kind of reminds you about you want to see the baby be pink. You know, blue is indicative of cyanosis and not enough oxygen. And so the blue side or the 0 side is we are concerned about this baby. Most babies, when there is, you are able to predict, typically based on gestational age and the progress of the labor and many other variables, how this APGAR is going to be. So typically you're not going to be surprised because based on the delivery, you know, and the fetal heart rate and D cells and all that you guys are learning, you would have some indication typically if you're going to be on this blue side. So it's usually not a surprise. You are prepared, and you may even have a neonatologist and some of those NICU nurses in the room when this blue side occurs. So 0 is worst case in each of these areas. 2 is the best. And it's pretty simple here. I think we talked about the limp baby with the poor muscle tone. If they're kind of moving around, then they're going to get a 2 there. A nice strong cry, strong respirations, they're going to get a 2. Grimace is related just to the crying. So if the baby cries, they get a 2. This is the only one here that is an actual objective taking the baby's pulse rate. And that would be the nurse who would do that. Like I said, when the baby is, we hope, skin to skin, that would be an ideal situation. The rest are just a little bit subjective. You hope they're not, but I did find in the hospital that it is a little bit subjective where you're saying whether or not the baby looks pink or blue. And we expect the we don't expect, but it's still considered within normal. Very often the extremities will have some cyanosis, but if it's all over, then that is indicative of something like an emergency situation, and you would quickly have specialists there to likely take the baby. And then this is just in words. I kind of put this over here for you. Students often stress about this APGAR scoring, but I think that I'm hoping that this makes it easier for you to understand. And maybe even if you draw this out once, or you could use this do kind of what I did with the pink and the blue, and hopefully that will help you remember, and not just remember, but kind of make sense of why this is important. And it's not much, it's just 5 different areas and what it might mean based on being in the different areas. Okay, vital signs for the newborn. As you guys can imagine, I had so much fun getting these pictures for these different babies. The something that was interesting to me when I first started on the mother baby unit is with the baby's GBS positive, you might be doing it more often, or depending on the facility, it could be Q4 to Q6 hours. But I want to go through with you how we do this. It's used to be kind of back in old school, they would do a rectal temperature because they thought that was the most accurate. And I understand from friends who work in the ED, if they get a baby, they're still doing a rectal temperature. I never saw this on the mother baby unit. And if you read all of the current evidence-based practice, we are not doing newborn rectal temperatures anymore. It's always axillary. And on the newborn or on the thermometer in the hospital, it's important to make that adjustment where you tell it that it's the axillary temperature, which is under the arm here. And you'll see nurses kind of put it in and poke it out this way, but really you get the best reading if you, and incidentally, I would like to note that of all of the assessments, babies hate this. And so as a newborn nurse, part of the teaching when you come in the room and you're making these assessments, you usually would do this one last because it's upsetting to the baby. And also just let the parents know, I'm not hurting the baby, but I just want to let you know that babies don't like this. They don't like you to lift their arm. They don't like this probe under here, but I'm not hurting them. So again, the way you do it is you would lift the baby's arm and you put the probe in lengthwise here, and then you kind of gently hold the baby's arm down to make sure that you get that proper temperature. And it's pretty quick that it comes up. And then as a newborn nurse, you want to know what's considered normal. And again, we are worried about the babies being cold. Typically, it's not very often that a baby is going to present with a fever. That's more on the mom side. More common, you're going to see a baby who's too cold, and then you're going to provide teaching and quick assessments for the parents, and you will make you will offer interventions to get the baby warm if the baby's too cold. And ideally, we put baby skin to skin, like I mentioned earlier. We reassess in a half hour, see if the temperature has gone up. Usually that does the trick. It may not, or you may have a mom who just says, you know what, I'm too tired, I need to rest, I can't do that right now. So then plan B would be dad can do skin to skin too. So you could, it's cute because I've seen dads come in and they have these shirts that are like, I don't know, they say something cute on them and they kind of undo like by a diagonal Velcro, and it makes it easy to put the baby skin to skin. And then it's kind of a blanket that goes over them. I've only seen that a couple times, so likely you're not going to see that, but you could say to dad, hey, mom's tired, do you want to try this? And they can, oftentimes they will just completely take off their shirt, or they can lift it, and then you put the baby onto their chest and you put a blanket over them just like you would for the mom. Dad sits in the chair, you get him comfortable, make sure he knows how to hold the baby safely, and then we come back in a half hour and we reassess. Very often that takes care of it and gets that baby above that 97.7. If it doesn't, depending on the facility, you could give it another half hour, sort of make some adjustments, keep baby skin to skin. After an hour, if the baby still is too cold, we could put the baby under the radiant warmer. And that's where you take off all the baby's clothes, because you're not, a newborn nurse told me once, which made sense. We're not trying to warm the blanket or the clothes or the diaper. We want as much contact with the skin as baby as possible. So we take off the baby's clothes. The radiant warmer is sometimes, depending on the facility, right there in the room, or we may say we've got to go take the baby to the nursery. You can, many facilities, a parent can come, or we can say, this is a good chance. You guys are tired, take a rest, the baby's safe. We're going to put the baby under the radiant warmer. keep assessing the temperature, and we'll bring back the baby once the baby gets warm. And then we'll continue to assess once the baby's in the room. Very often the parents are, as you can imagine, just exhausted. They've been through the whole labor process. It could have been over days, or even if it was quick, it's really emotional. They are at this high level of adrenaline, and then they're going through this adjustment period of taking care of this baby. And right now, with these times during COVID, their level of anxiety is at an all-time high too. So if there is a facility where you can, in your facility, offer a chance to rest, parents are now more than ever taking you up on that offer. And you check, part of it is you check the bands before, and then when you bring the baby back after. That's a huge part of this mother baby nursing, but just giving them a break is kind of a cool option. Okay, the other vital sign of these three is the heart rate. This kind of just gives you a little third to fourth intercostal space where you're going to do it. You can see a picture of somebody assessing the baby's heart rate here. You want to do it for a full minute. And very often our watches now, the smart watches, you can program it for a minute. So it makes it easy. So you don't have to just stare at your watch. You can just look back and it kind of goes off after it's been a minute. You have to get kind of used to this because a newborn's heart rate is way faster than an adult, and it just takes time and practice getting used to that. Blah, 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 blah. It's much faster than when you're listening to the adult patient. So you want to know, commit to memory what's considered normal, just like we do for the adults. When you're working with these newborns, you want to know what's normal. And after you've been doing this for a while, you kind of get used to the sound, and you can tell when it's going slow. And then with that full minute too, you can also assess whether it's a normal rhythm. Now, babies, very often, you would predict that it wouldn't be a completely normal, and it's normal to have or wouldn't be, when I say completely consistent rhythm, it's very normal for baby to have some sort of murmur, and it's where you hear it kind of change. And that wouldn't be an indication for a referral, just knowing that that is expected, where there would be some sort of like little pauses and breaks in the heart rate. Same with respirations. So we're going to count them for a full minute. You want to know the normal range. It's very different than the adult patient. And you would expect babies, when they're getting new at this breathing with their lungs, it's not going to be completely consistent. And you'll hear with your stethoscope, and you can even watch that there's little sort of breaks in breathing, and that is considered normal. The big thing is that you want to just make sure that they are breathing and they're not cyanotic. And there are other indications, which I'll go over with the abdomen and the chest assessment, where you may be concerned about their respirations based on what you see and what you hear. But for the most part, you would predict that it's not going to be completely normal respirations as far as normal, how they sound. There'll be little breaks. And again, just make sure that you know it's way faster than the adult patient. Okay. So you'll hear this in the hospital. They call it eyes and thighs, and hopefully you guys will get a chance to, if you have any offer, if you see that you're going around with that nurse and they're doing that initial administration of the ointment in their eyes and the 2 vaccinations, or the shot and the vaccination, do that. Don't be afraid. They'll walk you through it. It's really good practice for you. It's really not that hard. And also it's important, and on the next slide, I'll talk about why we get this, why this is recommended for all babies in the hospital, and what are the possible repercussions because a parent can say, no, we don't want this. And that's part of our culture right now, that there are parents who feel strongly about their babies not being vaccinated for sometimes everything, or for just a few things. And so we, as healthcare providers, it's important that we present them with the evidence-based reasons that we do this. And the hospital has handouts, we educate them, and we get consent before we start. But there are very important reasons why we do this routinely for every baby. We should do this routinely for every baby in the hospital. So right when that cord is cut or clamped, if there are indications that there may be any sort of incompatibility with the blood, cord blood, part of the routine is cord blood is sent to the lab to get to type the cross and type the baby's blood. Some hospitals do this for every single baby. Some of them only do if the mom's Rh negative, or if the blood type is O for the mom, is not related to where we do the RhoGAM, and that's the incompatibility of the blood. But if mom's blood is blood type O and the baby's blood type is different, the baby may be at higher risk for jaundice. So that would come back too. And when you're getting report about mom, it's very important to know what is mom's blood type, what is baby's blood type, and the Coombs test, whether or not they're Coombs positive or negative, which lets you know whether or not the baby may be at higher risk for jaundice. And also if we're going to do an intervention on the mom, which that RhoGAM shot, remember, is not for the baby, that's for the mom. So cord blood is sent to the lab. Then the eyes and thighs are done very quickly. This is a picture for you here. We do the vitamin K and the Hep B vaccination in opposite legs. You would chart which leg, and you guys can reason through that. Why are you doing it in opposite legs, and why do you want to know where you did it? If there was some sort of reaction, it's very, very uncommon that there would be, but you want to know which one they're reacting to. And then this is a picture of a sweet baby with the ointment. And it can affect how they see, but it's in the scheme of things, it's really not that big of a deal. You would do this typically after that golden hour when the baby's bonding with the mom and the baby's a little bit more relaxed and tired. And you got to kind of do it as a ribbon across here with the ointment. And please, please do that. If you get a chance to do that with the nurse, it's completely within your scope as students to be able to administer these beginning shots and ointment to the baby. Okay. So here's some pictures for you of moms who, or parents who might consider refusing eyes and thighs. I have some more notes about this too. So let's see. So this can happen in the this is showing a skin condition, which is related to the same thing that you get why they're putting that little ointment in the eyes. It's a really big deal. This erythema. You can have this the one in the eyes or on the skin, and it's a major reaction. I have another picture later where you can actually see the eye one. So this doesn't completely show you what happens when they refuse it. I have another one too where they show this is part of the rash part of that, where the eyes have this sort of gunky yellow stuff in it, and it actually is an emergency, and we'll go through that later. Now, this is a baby who didn't get the vitamin K shot. And the thing is that when babies are born, they so the vitamin K is to get so the baby doesn't bleed out, and it takes a few days for the baby to get this without getting the shot. And a pediatrician would, or who it could be a pediatrician, it could be the OBGYN who performs the circumcision. They would never do a circumcision on a baby if they didn't get the vitamin K because they're afraid they're going to bleed out. This is a picture of a baby who's having a major issue with bleeding on the whole body, as you can see, where there's sort of the bleeding is oozing through the skin because they didn't get the vitamin K shot. So it's simple, it's easy, and recommended. The thing is, you could, if you don't get the vitamin K shot too, you were doing, like I said, some of these other tests you'll see on the baby. And then also, if they get the Hep B vaccination and they don't get the vitamin K shot, then we're worried about them bleeding out because they don't have the natural clotting factor that we do, that adults have with vitamin K. So it's important to educate the parents, patients, when they consider refusing the eyes and thighs. And this is a picture of a baby who looks a little bit yellow, and that's a sign of one of the signs of hepatitis B, which of course is a liver disease, and a baby can get this transferred through the mom, and it's a huge deal, and we recommend that vaccination. And then there's the HBIG follow-up vaccination. if mom is Hep B positive. So this is about teaching, and us having knowing the evidence base, being able to properly and accurately and in a kind way that is receptive to the parents, teach them about why we want to do these eyes and thighs early interventions. Okay. So there are many risk factors for a baby being hypoglycemic, and it's important this can be a medical emergency. Well, just like it is for your adult patient, being hypoglycemic is a big deal. And as a nurse, we need to recognize risk factors before we get to this point. And I've listed for you here, it's important for you to know. And many of these risk factors are risk factors for other complications with babies too. So you've heard a common theme here going through about the LGA and the SGA. That is also a risk factor for hypoglycemia. Low gestational age is a risk factor for tons of different things, including hypoglycemia. And then, of course, if you have the mom who has gestational diabetes or any form of diabetes, so baby's getting all those high levels of glucose in utero, and then comes out, we're worried that baby's going to become hypoglycemic. Here's another, this is more rare, but recognizing when you get the history and you get report if there is any sort of family history, which could be a risk factor for hypoglycemia. Just being more astute, more aware. You're always watching for this, but you want to know ahead of time if there's more likelihood the baby could get low blood sugar. Then here too, I added a couple more. We always in report, we want to know if mom received no prenatal care, and depending on your facility, there may be a high population of moms who didn't get prenatal care, and you can kind of predict what areas where that might be. And if you don't have this, then you're more worried about all sorts of complications, including low blood sugar for the baby. And then this is again when the baby isn't able to, based on mom, grow adequately and mature the way you would predict based on gestational age. That would be another risk factor. Then, of course, any kind of stress or trauma during the laboring process or delivery puts the baby at risk factors for lots of stuff, including low blood sugar. Like I mentioned earlier, it's rare now that we have post-term babies, but that would be a risk factor too. So when you are taking these tests, whether it's the NCLEX or it's in school, or you're just out as a nurse, being able to use your wealth of knowledge and make predictions, these are common themes. If you don't know the answer and it says that they're LGA or SGA, or there was some sort of stress during the pregnancy or the delivery, those are likely going to be yeses on the select all that apply, because any sort of trauma or growth restriction or abnormality during in utero or during the birth process or immediately after is going to put, yes, the answer is baby's going to be at risk for lots of things. So answer is yes if it's these things. Okay, so you are seeing a theme of, we are talking about the baby adapting to being from the inside world to the outside. And this is just a cute picture of an exhausted mom and baby beside the mom. And you as a nurse are able to predict when the baby's going to be fussy or more responsive to feeding and being able to latch, and when baby's just going to be pooped and tired. And these are very predictable, and you are constantly, when you're charting for the baby, you see their age in the world. And so it helps you predict when you would see certain things and when you would expect certain behaviors of the baby. And this goes through, these are terms that are in your textbook, and they're pretty easy. I think it's important to commit this to memory and just have a general understanding of, so when this first period of reactivity, and it's 30 minutes, but really in that whole golden hour. And that's why hospitals have made this adjustment to having baby ideally with the mom in this first period of reactivity, because It's great for bonding. It's great for thermoregulation, and it's a great chance to get mom and baby introduced, especially if they want to breastfeed, getting the baby latched onto the breast. And mom often still has some sort of pain relief in her too. So just it doesn't hurt at all. She barely feels it. We want to show her how to do an appropriate latch and get that baby right when they are most responsive to latching on. Then very quickly after that is this relative inactivity. So the mom might be like, this, this can actually be a good thing because everybody's exhausted. But there are those moms who have this birth sort of plan and this idea of what they envision. And we want to give them reassurance if baby's not wanting to latch or not being responsive, that we kind of predict that the vital signs may chill, go down just a little bit, and baby may be a little bit difficult to arouse. And this may not be the optimal time to latch baby onto the breast or try a bottle if they have decided to formula feed. Then we have this second period of reactivity, which is very predictable with the babies, and we are teaching the parents about this. And this is when babies kind of get stuffy and snorty because they have this increased mucus production. And so it's okay, like I said, and appropriate to use that little bulb suction device if baby has mucus, or it could be just amniotic fluid that they're just trying to clear, to use that to clear the baby's airway. We would not put it in their nose though, because it could cause damage, and they have these tiny, tiny little nostrils. So that wouldn't be appropriate. Now that bulb syringe would likely be right here in the baby's little crib, kind of pointed down, and we would, when we are at shift change, assessing to make sure it's there. And the parents can use it too, where if they hear the baby choking or they think that they could have a possible risk for aspiration, they immediately lift the baby and they want to use that bulb syringe. And if they want to press the button to have a nurse come in quickly, but we want to teach the parents how to do that on their own, because we want to quickly be able to prevent the baby from choking. Okay. Okay, so this is the newborn physical assessment. This is typically would not be the role of the mother baby nurse. The weighing, like I said, we do Q shift, but these other measurements are often, depending on the facility, this would take place up on the labor and delivery floor before the baby is brought down to the mother baby unit. Or it could be that they have a newborn nurse who comes in to the baby's room and does this assessment. Or some old school places still want to take the baby away from the parents and do this in the nursery. Mostly the trend though is to keep the baby in room with parents the whole time, or as much as possible. So these are the assessments that will be noted. And I'm going to go, when we get into all the different systems and I talk about each individual system and what we are looking for and what's considered normal and abnormal, you're able to predict with these early measurements of what the abnormalities that you may see in the baby later in the stay. So we're not doing these circumferences and length throughout the stay. They typically just do this once. It's not going to change. And this kind of just shows the proper, the way that you properly make these measurements. And again, this would be with the newborn nurse. And it's pretty self-explanatory. They want to stretch out the baby here, usually on a chuck, and then they'll just make like a mark with a pen and then measure it. This one has the measuring tape right here, but usually in the hospital, I have never actually seen them put the measuring tape next to the baby. It's more like I just described. It'd be a little pen here and pen here. Then they can get the baby quickly back to the parents, swaddled, because we don't want them to be cold, and then make that measurement. And then the scale is important because we want to, like I said, unless there's some sort of unique indication, the baby's being weighed once a shift, or even every 24 hours. Actually, it would be every 24 hours. Usually they do it at night, and then maybe once a shift if they're more worried about baby. It's all about I&O and baby getting enough to eat. And the thing is with the trend with right now, we're really well, breastfeeding is a funny thing because it's natural. It's the milk is always the perfect temperature. It's free. It's right there. There's so many great things, the immunities it provides. But there's been trends over the decades of what parents are choosing for that. There was a period where it was kind of considered, oh, where you're poor if you are breastfeeding and you should get this fancy formula. And there are still cultures who kind of believe that. And so as educators, we certainly there are hospitals that are considered like lactation friendly or baby friendly hospitals, and they rely. It's very important for them to have a high percentage of exclusive breastfeeding moms, and so their approach to teaching may be a little bit more persuasive. But it's kind of like we do with any kind of nursing. We need to culturally and we need to, in all ways, show respect for our patients and their decisions. And so it's very, we want to educate about breastfeeding, and we would, as nurses, we see all the wonderful benefits, and we hope that all the moms, or at least try breastfeeding. But, if they tell us that they, for whatever reason, are going to feed just formula and by bottle, it's important that we are respectful of that too. And we can gently nudge, or we can we can kind of assess what the reason is. And if they maybe had a bad experience in the past, or whatever the reason is, if we feel like that we can properly mitigate them and mitigate that reason and offer assistance to get the baby on, very often I find that they'll take me up on that offer. But it's like everything. We want to be very considerate of everyone has their own unique situation and reasons for why they do things. Back to the reason I bring all this up is because if mom is exclusively breastfeeding, we can't measure it. And the way we chart this is by time that the baby's on the breast. And so typically every 2, sometimes to 3 hours, if mom's exclusively breastfeeding, we will go in and we will say, it'll be very typical that would say right 15, left 15, which indicates that the baby was on the right breast for 15 minutes and the left for 15 minutes. And then we would teach mom to start with the other one next. And it's very often that the baby will be more comfortable, and or mom will be more comfortable on one side. And so we understand that, but we want to teach that the other side can get engorged, and even they can get something called mastitis, where they get an infection and a clogged milk duct. So we really want to encourage at least trying on both sides. And the way we chart, sometimes moms will be like, oh, but I don't know if they got that much, or they were kind of just falling asleep. We don't have an objective way to measure how much did they really get. So everything, whether or not the baby is actively sucking or just sort of resting at the breast, we still consider that as that amount of minutes for the baby being on the breast. We also keep track of the newborn diapers, and we teach the moms and the dads that every time when that mother baby nurse goes in, we ask how many minutes and or how much formula was fed, and then that's done by mLs. And we also keep very careful track of how many times the baby urinates or poops. And it's atypical, I think, in the hospital these days to actually weigh the diapers unless the baby's high risk. You would do that in the NICU. It's more just how many wet diapers and how many stools they have and how often. And at our facility, they have these cool diapers now. And I think this is kind of the trend, where there's this yellow line that kind of goes up the diaper. These ones I think are made by Pampers. And it, so as you can imagine, if baby pees and poops, it's hard to know if there's really pee in that diaper. But there's this pH level that with these cool diapers now, the yellow line turns blue. And part of our teaching is teaching the parents about how to recognize if there's pee mixed with the poop, and to let the nurse know, oh, the line was blue, so we see poop and it was pee and poop. Or if you're just, the baby's clothes are off and you see the diaper and you see that it's turning blue, oh, that indicates that there's urine there. So that's pretty cool. And they haven't had that forever, but it's really helpful for the nurses and for the parents. Okay. assessment of color. This is part of our overall assessment of the baby, and being able to recognize if something could be something serious. And this kind of shows this cyanosis that's just limited to around the mouth and the baby's extremities is we will continue to monitor, but that is considered within normal range. It's when you see more of a central or cyanotic look, aside from just what we see here, then we're worried about oxygenation of the baby, and that would be a call for further assessment. Um, this is a baby with jaundice. You don't always see this, but this one clearly you can see the yellowing of the skin. Um, it typically starts from the top and goes down into the extremities. So if baby's abdomen is now yellow, that is an indication of likely a higher bilirubin level, and we are starting interventions. And I'm going to go through, there's a test that we routinely do called a TCB, which stands for transcutaneous bilirubin, and it's non-invasive, and it's kind of almost just like a temperature thing that you put on the baby's forehead, and it gives you an indication of their bilirubin level, which lets you know about whether or not the liver is able to properly get this bilirubin out to prevent jaundice. So if you notice the baby's already looking like this, and it's not time to do that TCB, which is typically at 24 hours of age and then at 36 hours of age for a normal newborn, then you could do a spot check. And that's where you could do the transcutaneous bilirubin at any time on the baby. If you see an elevated level, and different hospitals have different policies. And again, that's based on gestational age. And there's this thing called a Billy tool that's part of many charting systems that quickly tells you what level of bilirubin based on that TCB is appropriate or what level requires an intervention. The next intervention, because the TCB is just considered a screening tool, is a serum bilirubin draw. And that's where that's often done on the mother baby unit, or in some hospitals, they might call the lab in, and they draw the blood, and it's a very quick answer, which is now this is a diagnostic test, and it tells you the exact level of the bilirubin as opposed to just a screening. And that's when you would reach out to the pediatrician, which may call for interventions. Very often the first one is a Billy blanket or Billy lights, different things that help get the bilirubin out. You want to feed the baby more because the way that the baby excretes this undesirable level of bilirubin because of the immature liver is through stools and urine, through output. So we would often feed the baby more if these levels are high early on. And this may be one of those few indications where if we're worried about mom who is exclusively breastfeeding, not producing enough milk right away, they may recommend supplementing with formula, or they may not. This is, it just depends on many factors. And jaundice is a really important deal in newborn nursing. And I have several slides later where we're going to talk more in depth about that. So this is a baby who you probably can tell looks a little bit pale, and you might predict that the H&H is low or that baby's hypoglycemic. And so you would follow up if you saw a baby who looked like this, maybe do a blood draw or quickly do an AccuCheck and measure the blood glucose. This is a baby who looks really red, and this may be a result of polycythemia. And again, H&H would indicate whether or not that's going on. And you can tell that you can see a lot just on how the color looks. That's just a quick assessment. And then that could, based on seeing this in a newborn, lead to further assessment. Okay, now we're going to talk about the skin. Baby's so adorable. Okay, so let me see more information on this. These are very typical presentations that you would see in the hospital. This milia, it looks kind of like little newborn pustules. This is really normal, and it's most often on the nose or the cheeks, like you see here with this baby. And we want to reassure parents that this usually resolves in the first couple weeks, and it's just a result of just sort of hormonal changes in keratin in the nose, and it's called milia and it's normal. And you guys want to be able to recognize this. It's pretty easy. It doesn't look any different from, I mean, it looks very different from other manifestations in the skin, and this is milia. Okay. TK is, so these are like little pinpoint flat hemorrhages that you see very often on the head, the face, the chest. And this could be related to a rapid pressure or rapid delivery of the baby during the birthing process. And it typically doesn't progress or lead to anything greater. The neonatologist or pediatrician may recommend a platelet count just to rule out any sort of disorders, but very often this is considered normal, and if there's not any other bleeding present, then we would just continue to assess. This is called a newborn rash. This, you see this in almost all babies. This is the big word for it, erythema toxicum, but we call it a newborn rash. We chart it as a newborn rash. And again, you as a nurse would want to offer reassurance to the parents that this is a result of hormonal shifts. You wouldn't likely see this right away, but around 12 hours-ish, we almost always see this in babies. And we chart it and we reassure the parents that this is considered normal. So I hope that you can see in these pictures that these three different skin presentations are very different. This is like pinpoint little red is different than this sort of widespread rash looking. That's sort of more swollen. It's got clusters together. It's bigger. It's not pinpoint. This isn't even red. It's just these little sort of white looking pustule things. So hopefully these pictures have helped you. Maybe when you are preparing for your exam, or as nurses, when you are on this mother baby unit, you could just take a quick picture or a quick look at these pictures and find a way to be able to recognize and understand the differences here, and that they're likely will not lead to anything serious for the baby. Okay, so these are just two things on this page here. This is just two different representations of the same thing, this strawberry nevus. And then this is the port wine stain. This is two different presentations of it. These pictures that I provided for you are big or sort of severe presentations of both of these. They can be much more subtle. They can be much smaller, but I want you to have a general understanding of what they look like. When you look closer, they're very different. Okay, so they may be a similar color. I think Gorbachev has this thing on his face too. This is very often permanent, and if somebody desires, they could get laser treatment later in life to remove it. They're both harmless. This, the way it's different is it's raised, and this is smaller, but you can see it kind of looks like a strawberry. It's very different. The two are very different, and you want to recognize that the blanching with the pressure is different in between these two. That's another way to differentiate between the two of them. So hopefully you can eyeball that, understand that this maybe looks like red wine, is like you would see that if it were spilled on a carpet or something. This doesn't look like wine at all, and this is raised more like a strawberry. Okay, so this lanugo is very normal for a newborn. It's just like hair. They may come out and look really hairy. This is more common in darker skinned babies. The hair may fall off. It usually does fall off in the first couple weeks. There's a genetic component, but it's completely normal. There's no indication that there's something serious going on just because the baby's a little hairy. This is considered normal. This is a baby. You can see there's different levels of this, and you would just chart that that's normal peeling on a baby. Modeling may be more, let me see if I can actually, I think I have some good notes for you guys on this. Okay, here you go. Um, this is, this modeling is transient, like it says here, and it's a normal newborn finding. And then this stork bite here, you can see here on the notes. I'm going to give you guys a copy of this PowerPoint too. And I have notes on almost every slide with citations. So you can go if you want to read more and get an understanding of this. I wanted to point that out to you. I'm going to go ahead and close it so you can see the pictures better, but you will have access to those. And then this is, even in the charting, you'll see it'll say stork bite or salmon patch here. It's very often it's light and it's right here. Very often you'll see one that looks like this more here, but it could present on the back of the neck as well. These very typically fade, and these are normal and expected, and we are not worried about any sort of condition based on a stork bite. But again, you want to differentiate this from this. So the stork bite looks very different than the port wine stain and looks very different from this strawberry hemangioma or nevus. Nevus just means birthmark. So if you see that word, it just means some kind of mark. So this and this, I don't want you guys to get confused with this. They look very, very different. Stork bite is small, it's going to go away, and it's this light pinkish. Okay. These pictures that I have here are like with the other ones. These are sort of extreme presentations of these conditions. They are harmless and they are oftentimes genetic, but very often I've never seen one look like this, but I just wanted you guys to get an understanding of what a Mongolian spot looks like. It's very often sacral. We'll call it a sacral Mongolian spot, or on the buttocks right here. And it's typically not this blue in color. It's very light. And the way you chart it is, again, sacral or on the buttocks or on the back. We say where it is. And this is very common in populations with a darker complexion. Almost all Hispanic babies will have some form. Like I said, I've never seen this extreme, but some form of Mongolian spot. And whenever I'm doing a newborn assessment, I point out everything to the parents, just because you want to also differentiate this from bruising and let them know it's not a bruise. Or they may say, hey, I was worried about a bruise somewhere, and maybe there's something that really looks like a bruise. But the parents are really your best historians. They can reiterate stuff about the delivery or stuff they've noticed on their babies. And so if we work with them collaboratively, we can say, I want to point this out to your baby. Here's what it is. It's harmless. And with Mongolian spots, very often they'll say, oh yeah, all of our kids had it, or we have it, or we had it, and it's expected. But if it's their first baby, then you have more opportunity for teaching. These cafe au lait spots look different. I want you to note that they look very different from each other. So you want to be able to distinguish this. These are light brown. They're usually more like this and smaller. They, you would note where you see it and also educate that it's not a bruise, although this one isn't as often mistaken for a bruise because of this light brown color. They may fade, they may not. Now, if you had an infant, this is a picture of a bigger, I'm not sure how old this child is, but it's not a newborn, with multiple cafe au lait spots. If they presented like this as a newborn, this may be an indication of possible other genetic conditions. So if I saw this many cafe au lait spots on a newborn, then I would go ahead and just point it out and bring it to the attention of the pediatrician or the neonatologist if they didn't already know. But more often than not, you're not going to see these many. They're going to be lighter and they're harmless. So be able to recognize the difference. Hopefully that was a good explanation. You guys can understand the difference. Almost never leads to anything except for what I just described here, which I've personally never seen. Okay, here's another adorable baby, and we are going to talk about assessment of the head. So right away, so this is 3 different conditions. This one right here is considered normal and expected. And almost every vaginal delivery, the baby's going to have some level of molding. And you can kind of see in this picture, but this is one of those babies that kind of looks like a cone head, because the baby's head has the ability to sort of shift and change to come out of the birth canal, which is a beautiful thing to get the baby out. But then it looks a little misshapen when they come out. And we reassure the parents that this is normal. Molding will almost always resolve itself in the first few days, if not couple weeks. And it's not an indication of any condition except for the baby's head was able to adapt and come out of the birth canal. Now, these two words here have to do with a baby's head being too large or too small. And this you would identify back at that first assessment where I showed you guys the picture of the head circumference in that initial assessment of the baby where they were measuring. And based on gestational age and the year and birth, and so gestational age, and then how old the baby is on the planet, how many hours, we have charts that will let us know what would be an appropriate head circumference. And these are bigger, these are a big deal. And I think I wrote some good notes here for you too. So this small head is very often associated with chromosomal abnormalities. It is Down syndrome is a big one, and many abnormalities that are genetic or chromosomal are associated with the head being too small. So you would likely see this condition associated with other abnormalities that you're seeing in the baby too. But this is indicative of other problems, unlike molding, which is considered normal. And then here, this is very often associated with increased intracranial pressure, where it's sort of spreading out and making the head bigger. It also could be associated with genetic abnormalities. These two babies would in almost all cases be in the NICU and wouldn't be on the mother baby floor. And so if you saw this on the mother baby floor, then it would be a reason to get some sort of referral and have somebody take an extra look, but you likely would not see it. Okay. Okay, so we are going to talk about two conditions here. It's the cephalohematoma and the caput succedatum. We just refer to as caput oftentimes in the hospital. So I want to go through, you can kind of get a preview on the side here that I have two slides that describe both of the conditions, and then the third one kind of tells the differences, because it's important to know the differences. And I'm hoping that these three slides will make it clear and easy for you guys to understand. So this is more of a bruise. So cephalo means the head and hematoma is bruising. And this is very well defined, as you can see in this picture. And it is typically not an indication of something that is severe. It's very often related to how the baby was delivered, maybe with some sort of assisted delivery, which I'm going to go through very shortly here too, about forceps and vacuum extraction. If you saw this on the baby and you're a nurse, you might want to look back at the delivery record and you would predict that it was likely not an easy delivery. The big difference here is this is well defined, and it does not cross the suture lines. And remember, baby has these soft spots and clear suture lines here. This stays in one area. It's like a bruise, and it's well defined. Okay. This one, caput, which we see this all the time. The cephalohematoma usually comes later, is not when the baby's still in the hospital. So it'll be very unlikely that you will see that showing itself on the mother baby unit. This caput is very common. It's kind of when you palpate or you feel the back, it's very often right here of the newborn's head, it feels squishy. And you'll see it sort of swelling back here. So it doesn't feel like a hard, firm skull. It's like this squishy sort of fluid feeling back there. And so we would teach the parents that that's edema, and that's normal. And we're usually not worried about this being anything more serious. This is very often related to the delivery as well. And most importantly for you guys to distinguish the two is this is not really clearly defined like the other one was, the hematoma. This is a generalized fluid collection, which may be back here too, and it crosses the suture lines. It's kind of all over. It's not just one area of a pocket or a bruise. If you chart this, you're not worried, you're watching it, but it's a normal checkbox on the mother baby charting. Cap it. So I brought in a little chart for you guys here, and Professor Nicola is the one who introduced this idea of thinking about a baseball cap with Cap It. And that really helped me remember, because I think a baseball cap goes over the whole head. So remember, when you have Cap It, it's all over here, and it's that squishiness that crosses the suture lines. This over here is a bruise of the head. So this is just a silly picture, but if you think of a bruise, it's very clearly defined. If you have a bruise anywhere, and it's going to stay localized, and it is that same collection of blood anywhere on your body, where this is related to edema, this is bruising, and this can take longer to resolve. And like I said, it typically presents itself after mom and baby have already been discharged, which is usually 2 to 3 days after the baby's been born. So you want to, for NCLEX and as students and as new nurses, understand there's a clear distinction, and I hope this has made it easy for you to understand the difference between the two. They look different, they feel different, they mean different things, and the baseball cap and the cap hopefully will help you remember this one crosses the suture lines and is a squishiness all over, as opposed to a localized bruise. Okay, so this sweetheart baby was born as a result of some sort of assisted delivery. So when a baby is born vaginally, it all of a sudden becomes an operational delivery if you use some of these interventions. So there's a cesarean section, which is invasive, and the baby's not coming through the vagina anymore. But there's also assisted deliveries, operational deliveries through the vagina, and there's a great reason to do this, all sorts of reasons, which I think I go through briefly here, where the baby's already engaged in the birth canal and we got to get that baby out. These are really helpful, but you may expect that there are certain presentations for a baby after an assisted delivery. I just put some pictures of equipment here for you. I know that when I working on the mother baby unit, I'd often see the word Kiwi there. And this is kind of the go-to for vacuum assisted. And I never knew what it looked like before I actually looked it up for this presentation for you guys. And it's this is vacuum delivery equipment here, which is more old school and is still used in the hospital. And depending on, very often, the doctors will have their sort of preferred go-to. And so it may be with one of these, or very often it's this new Kiwi thing, which is a one-time use only. And this is more flexible and soft, and it's able to sort of rotate to be able to attach to the baby's head, where this is more rigid. And so the cool thing about this is that it can rotate with the baby's position, and oftentimes isn't as doesn't leave as much of an impact on the baby's head. And also, research has shown that use of this Kiwi device over the typical vacuum delivery equipment is less tearing for the mom or need for a episiotomy. This is a smaller device and less invasive to get the baby out. So the big takeaway from this is it's helpful to the mom too, not as disruptive to the perineum and vagina and getting the baby out. And this is a picture of forceps, kind of shows you about how big they are. And there are reasons to use forceps instead of a vacuum device. And I'm going to quickly show you that in the next slide. To me, these look kind of scary. They probably do to you too. So if this would be the doctor's role, to teach and talk to the parents about why and when these are going to be used in getting the baby out. You as a mother baby nurse, we're talking about newborns here, you're going to get this in report. And if it was a forcep or vacuum assisted delivery, you may expect some of the stuff that we're going to see on the next slide. So this is just another kind of picture where you can see rudimentary what it looks like. This kind of grabs onto the baby's head. This applies the suction. It could be on their face or their head where you would see bruising. It's not a medical emergency, but it would be for a teaching opportunity and for the nurse to be able to assess and watch and explain to the parents. And they likely already know, but we wanted to just watch the bruising. This baby's really bruised on the face. This one, let me see if I can make this bigger so you guys can see. Okay, yeah. So that's a laceration. And this can happen too. So we assess this, and this is kind of hard to see on the mother baby unit if the baby's hair, like if the baby has a lot of hair and if it hasn't been washed, you really have to look and you have to have good lighting so you can assess and watch what's going on the newborn skull. We see that quite a bit too. Depending on your facility, how often this stuff is used, you may or may not see this stuff often. This poor sweetheart has a big forceps mark on her face. It's not ideal to grab the baby by the face, but in this situation, obviously that's what they found needed to be done. And then here's a vacuum mark on this baby too. So no cause for concern. We would chart it and we would be able to recognize why it happened and what it looks like. Okay, now we're going to talk about the eyes, ears, and mouth. Take a moment to look at that sweet baby. Here's the eyes. Okay, so this is the picture that I wanted to show you earlier about parents refusing that eye ointment where we do the ribbon across here. This is an example of a baby who has very edemic eyes and has this infection in the eyes. This is a way bigger deal. So this is actually just conjunctivitis, which is like getting pink eye for an older baby. That's what this picture is. But if you get this as a newborn, it's a way bigger deal than an older child getting pink eye. So this is considered an emergency. And this is also what it would look like if the baby had the gonorrheal conjunctivitis too. And again, that's why we encourage that quick eye ointment intervention. Eyelid edema, this is very, very common in babies. We chart it, but it's normal. And we explain to parents that that's just part of the fluid shift and the baby coming out. Babies are very often edemic, and we see that in their eyes, normal finding. This is also a normal finding. So this is where you see this, where the baby's eyes are kind of weird because they're sort of darting and looking around. We would chart that, but then also recognize that if one eye is doing something different than the other eye, that would be a reason to bring that to the pediatrician or neonatologist's attention, because that could mean something different with the eyes. But normal disconjugate like movements like that, we expect that in the newborn, but we chart it. Okay, here's the ears. Normal ear has all the different parts of the ear. This is how almost all, well, actually, this is normal. This is what you see in newborns, but this is really common too. So this is a preocular pit right here. This is often genetic. It's just like a little sort of indentation. You would chart it. There are other bigger forms of this, but even this is important to note, and it's almost likely doesn't mean anything, but it is also could be related to a problem with the kidneys. So if a baby had some sort of kidney problem or you were concerned, this could be related. So you chart it and you mention that to the pediatrician as well, but very often you'll look and mom or dad will have this too, and it's just genetic. So this word just means some sort of problem with the development of the ears, and it's done in grades. And this is kind of shows a little bit of an abnormality of the ears and the development. It's not full and clear like this. And this is a grade 2 here. And this is where the ear is almost missing, which these sorts of things are often related to other chromosomal abnormalities. This is a very unusual finding in a baby, but I'm just showing you this is more important and common for you to know. This as well. So this is a low set ear, and this is very often associated with abnormalities, specifically Down syndrome. And the way you know that is low set is this outer canthus of the eye should be lined up with the ear. You shouldn't have the whole entire ear under this outer acanthus. So this is definitely a low set ear and could likely mean something else. Now it might not. This ear is a little bit formed abnormally as well. This is usually benign and means nothing. So this is the tragus here, and this is what's called an accessory tragus. And you would note that, and you would let the pediatrician know, but this typically low set ear is going to mean more than this. For this is just a general overview of the ears. This is the one that you, when you're working in this unit, that you would more often see, and recognizing what a low set ear looks like. Here's the mouth. So we're going to assess the mouth and reflexes, which I'll talk about later, but this is called an Epstein pearl. It's very normal. It's like this shiny white thing. This would be part of the charting. It doesn't mean anything. Sometimes you'll see a baby who's born already with a tooth coming out. Usually it's very mobile, and the pediatrician can kind of just grab it and it'll come out. There are other times when they might have to go back and do a bigger intervention to get it out. But like I said, likely usually it's just sort of like hanging there and they can just get it right out. Not a big deal. This is not a big deal either, but it is, the problem is that this can get in the way of the latch. This is a bigger word for tongue tie. So this is a big assessment on mother baby unit, because if baby's having trouble latching and you look at the baby and get in good lighting and you see that this is here attached, or there could be something attached at the frenum at the top as well, where the baby can't properly, the frenum, which is that piece of skin right there, inhibits the baby from being able to properly like flange out and latch on the breast. This is typically a very easy little snip that the pediatrician will perform, and it releases it and the baby's able to get a good latch. So if we are helping mom with breastfeeding or even bottle feeding and assessing baby's suck, we are looking for this tongue tie. This is an example of a cleft lip, and you also are assessing the top of the palate to make sure that it's completely closed. This also can get in the way of the latch and breastfeeding, but it doesn't mean that the baby can't breastfeed, and you would just maybe refer to a lactation consultant or give mom a little bit of extra support with breastfeeding, and then the pediatrician would follow up on the cleft lip or palate. The cleft palate's a bigger deal. That's when the palate is an opening under here when you can feel it. But there would be interventions for that later. Us as newborn nurses, we just want to make sure that baby can adequately feed. Okay, here's another adorable picture. I'm gonna go through this assessment. So these are typical, more common things that you would see in a baby. Common meaning this is not expected and not normal, but things that you might see that are unusual and more common with the baby. Broken clavicle, you can kind of see here. This may have been a difficult delivery. It may have been shoulder dystocia. The baby is, this will often resolve on its own, or they may end up putting sort of like a little, like they sort of tie gauze around and attach the arm so the baby doesn't move. It does the baby, if you were to lift up the arm, that's going to cause pain for the baby, but it very quickly typically resolves. It's just recognizing not to hurt the baby and bringing that to, normally they already know about this, but if the baby comes to your unit and you can palpate and it kind of feels a little bit like crunchy right there too, if it's fractured or broken. So that's something that you would recognize. I'm going to go to this one next. This is hip dysplasia. This is a Pavlik harness. This is the intervention that would be after, typically when the baby, is off your unit. They may wear this related to hip dysplasia, and you can easily recognize it here because when you're putting both feet flat, this knee is lower than this knee, and you can see that here. Also, when the original assessment, the newborn nurse will kind of rotate out the hips and may feel a popping or hear something that could be indicative of hip dysplasia as well. I'm going to go back over here now. So this is, you're just doing a quick assessment and you see this transverse palmar crease here. Sometimes it's completely normal. Sometimes the parents have it, but also this is a common sign in babies with Down syndrome. And so you would likely, if you saw this, see other abnormalities as well. But if you just see this and the baby looks completely normal and you just chart it, bring it to the pediatrician's attention. And just because they have this does not mean that they have Down syndrome, although they could. Quick assessment here, syndactyly and polydactyly. So this is where two digits can be fused. It could be more, it can be different toes. It's less of a big deal when it's going this way, like if it's these toes. If it includes the big toe or the big thumb on the hand, the thumb on the hand, that is, so the intervention for this is surgical, and it's a more complex surgery when it has to do with the bigger side. But it's not just a quick snipping. It's there's nerves involved here, and these may be attached, and so they have to do skin grafts to make sure they're both covered. It's a little bit complicated, and typically this is done before 6 months of age, but it's not a medical emergency. This is more common than this. This is where baby has an extra digit. You can see it kind of hanging off here off of the pinky. So like I mentioned earlier, this is typically not as complicated as if it were hanging off the thumb. Anything related to the objective thumb over there is a bigger deal. Sometimes they'll just tie, if this is teeny and it's just by a little tiny piece of skin, they'll tie this off, the doctor will, which will stop circulation and it'll just fall off. Or if it's more complicated, they may have to do a little surgical procedure to get that off as well. So you would just see that, chart it, let them know. Okay, chest and abdominal assessment. So this is when you are assessing the abdomen. It's for two things here on this slide. It's related to retractions, to way the baby presents. And then there's also skin and prominent xiphoid here. This is, this could mean that you do not expect any these sort of retractions in any way, and this is likely some sort of respiratory distress. You may see other things like nasal flaring and cyanosis and other things to indicate with vital signs that baby doesn't have an adequate respiratory effort. This baby is typically in the NICU here with these retractions. If you see this, you're concerned about respiratory depression. This is just kind of where the muscles are separated here. This is not a big deal. There's not any sort of intervention. You just want to note it. And this often resolves as the child ages and isn't typically any indication of any kind of anything respiratory, but you would just note it. This is kind of like, you can see the nipples way over here, like it presents as not a symmetrical appearance of the abdomen. This is basically extra nipples, and you would note this. You can see them here. It's harmless. It's more common in African-American babies, and you would chart it and point it out like we do everything, like I do, is just bring it up to the parents and just let them know what it is and that it's normal, and we're just gonna note it. This prominent xiphoid process is more common in babies of lower birth weight or thinner babies, and usually on its own doesn't really mean anything, but you could, like everything, point that out and just continue to assess and watch, but it likely doesn't mean anything at all. Continuing with the abdomen, a normal newborn abdomen is slightly protruding, but not distended like this. This could be, this baby's in the NICU. It could be pressure. It could be some sort of abnormal organs in there. Like I'm going to talk about this poor guy in a second, but this is not expected, is not normal. Little bit protruding, yes, normal. Distension, not normal. This could just be normal, and if this scaphoid abdomen is not on its own any sort of medical emergency, but you would, like everything, you would assess respiratory effort and you would watch for retractions on this baby as well, and you would note that because that doesn't look symmetrical either. Okay, so this little guy here, this is when basically the intestines are outside of the baby, or it could be any kind of organs. And you're not going to see this baby on the mother baby unit, but just knowing this word, and you might see it on NCLEX. And the intervention is they almost always know this ahead of time. But if the baby didn't have any prenatal care and comes in and is born in the ED or something, it could be a surprise. They immediately put something sterile over this, and they're trying to keep blood flow to this area as much as possible. And then that baby's going to go in for an emergency surgery. You could see this on mother baby unit, and that's basically poop or meconium stained umbilical cord. It's not a medical emergency. You would note it, you would clean it. And this is likely this baby was in some sort of distress, or it's what they call a mech delivery, where the poop comes out with the baby and we are worried about infection. So this is just another indication that the baby was delivered or had meconium in utero. And we just really monitor those vital signs. It'd be like a GBS baby, that's group B strep, where we're watching closer for infection if we see this, but not an emergency at all on its own. Okay, on to normal genitalia for the baby and rectum. So I don't go into a ton of detail here, but I want you guys to recognize this sacral hair here. This is like the other lanugo hair. It's not a medical emergency. You just chart it. This is very often genetic and a normal finding, but you just, everything that you see though, you're still going to chart. You're also looking, part of your shift assessment of the baby, every single nurse needs to go and you sort of spread the anus area apart like that, and you're looking for sacral dimples. Now this superficial dimple here, you're going to chart, it likely means nothing. When you get a deeper dimple or a hole here, this is a sign of possible spina bifida. And so that would be a baby that, like I said, if it's deeper or more prominent or open, that baby's going to be in the NICU. So you're assessing that every single shift. This is how you assess the newborn penis and scrotum and testicles. You sort of this is Q shift 2. Every nurse needs to document that the testicles have descended. You're looking for the complete genital assessment is done by the pediatrician, and if there's something that looks unusual, that they're going to have that baby in the NICU too. But we just kind of put a little bit of pressure up at the top here to sort of, you just press down on up at the base of the penis and then gently palpate here. And you want to feel for a testicle in the scrotal sac here. You want to feel for 2. There may be one undescended testicle, and you would just note that in your charting that you didn't palpate the left or the right or whatever, and let the pediatrician know. Very often that just resolves on their own. If it doesn't, there's a surgery that they would do to bring it down. But that is our assessment. We're just making sure that there's no obviously bleeding or pus or anything. This is a normal newborn penis that you can see here. And if we saw something that didn't look normal, then we would just chart it or let the pediatrician know. This is a girl, and this is normal as well. One thing to know about newborn babies that is normal but may seem unusual to you or to the parents. First of all, notice that this particular picture is the pigmentation is a little bit darker here. You could see that in the scrotal sac of the newborn baby as well, where it's darker than the rest of the body. That's common in darker skinned babies. And so very often, even the darkest of African American babies will come out looking kind of white, but sort of a little rule, and it's not a sure thing, but we notice that the genitalia is more an indication of what their real color will be. So you will, first of all, this is normal, but it also, you could tell the parents, typically this is how we predict will be the final color of your baby. They kind of get a kick out of that, and again, reassure them that it's normal. For the baby girl, you may see some discharge that looks like sort of a white discharge that's hormonal and considered normal, and you chart it. Or you may even see a little bit of blood, which is also considered normal, and it's related to the hormonal shift. It almost looks like a period, or it might just be a couple of drops. You might see it in the diaper. You might see it on the exam. You would just take a wipe and gently wipe it and reassure the parents that that's normal. Okay, so there are many screenings. Again, the difference between a screening and a diagnostic test is a screening is kind of just a first look at things, is not, it doesn't tell you for sure anything. It's the first sort of look at, hey, we may be concerned about something. This next slide goes through the typical screenings that you're going to see for every single baby in California. And then I'm going to quickly go through how you do them all, because as a newborn nurse on mother baby, you're going to conduct these screenings. I talked earlier about the TCB bilirubin. That's what this is. I'll go into more detail on the next slide. This is a CCHD or CHD. Sometimes they call it screening in the hospital. This is really cool because it's non-invasive, and you put this little, it's basically like a pulse oximeter where they're measuring the oxygenation. You do it on the right foot and then on either the left or right hand of the baby, and you compare oxygenation from the upper and lower extremity. And this they found is a great screening for all sorts of for heart or abnormalities where the blood is not being the oxygenation is not the same perfused from the upper to the lower extremity. And this can be a very good early warning that you want to do another test for cardiac because of this very quick non-invasive screening. This just shows you there is a little heel stick that you're going to do. It's different than the Accu-Chek. It's sort of long and it's vertical. It's not just the poke in that you would do for an Accu-Chek because you need a little bit more bleeding. I'm going to go quickly through on the slide about how we do that, the right technique. And this is this is the California newborn screen that's required. This has to be filled in a very particular way, and then this is sent out to an external lab, the same lab for everyone in Sacramento. They then send the results back to, it's important to have the baby's pediatrician's number on that because it goes to the pediatrician. And then when the parents go back for their follow-up check, the pediatrician will have the results. This screens for all sorts of metabolic disorders. It used to be just called the PKU test because it was specifically for PKU, which is still included on the test, but now I think it has over 100 early disorders that it can screen for. So just with a little heel prick, we can quickly identify if something's going on and then provide early intervention for the baby. Additionally, a newborn hearing screen is done on every newborn in California. This usually is not the mother baby nurse. It's somebody who is hired by the hospital and just does the screenings all day. It's non-invasive. They just have to have a quiet, the room has to be quiet when they go in. They typically do this in the patient's room, and doesn't hurt them, and they are able to early screen for hearing difficulties, and the results will come back and indicate there may be a problem. Again, it's not a test, it's a screen. And they'll have, the other thing is you just tell the parents they'll have sort of like goop, like ointment around their ears after they have this. Okay, so I'm going to quickly just go through these for you, show you what it looks like. This is the TCB, or the bilirubin meter. And like I said, bilirubin, the excess starts at the top of the body and goes down to the bottom. So if you saw yellow feet or a yellow abdomen on a baby, you're concerned. This is done unless there's some sort of indication to do it earlier. In almost every hospital, it's done at 24 hours and it's done at 36 hours, and it's charted on, so there's like a little chart where they put the level of the bilirubin based on the baby's age in the world. So this isn't gestational age. This is like 24 hours, what we would expect the bilirubin to be, the level. And in a normal adult, we would not have, our liver adequately gets the bilirubin out. We wouldn't expect any level, but a baby has an immature liver, and based on how old they are, we would be able to predict what it should be. And if it's too high early, we quickly do an intervention. The way you do this is it just gently, you press it down, it gives a number. You do it 3 times, you press a number. Usually you do it twice. You do it once on the forehead, Then it'll say ready. And you do it again on the forehead. It'll say ready. It'll give you another reading. And then you do the third one, usually on the abdomen, or some facilities do all three on the forehead. It'll give a third number, then an average of the three numbers. And usually, like at 24 hours, if it's over 8, then we are doing a real test now where we're drawing a serum bilirubin and we're double checking that it's really high. So that's easy and quick, and you're going to do that on the mother baby floor. Do that if you can when you're in the hospital, if you get a chance. Here's the hearing screen. Like I mentioned earlier, it's non-invasive. There's different companies that where the electrodes may look a little bit different in the babies within your hospital. You're likely not going to do this as a mother baby nurse because you don't have to be a nurse to do this, number one, and they've likely hired somebody to come and do this for all of the babies, and that will be charted by them. Then at discharge, when you are going through the discharge as the mother baby nurse, you will show them their score, and you'll say whether or not they have a referral, if their baby passed or needs a referral for after their newborn hearing screen. Okay, this is what I told you about earlier. This is really cool. It's easy, except that it doesn't hurt the baby, except that babies are annoyed. They have this natural reflex where they want their hands clenched and they want their feet kind of rolled as well. So when we put this little soft thing that doesn't hurt them on them, they might cry and get upset. This test is not accurate if the baby's crying. So it's important to keep the baby calm for this. Usually with good technique, we can keep them calm. If not, then we want to consider giving them a pacifier, or maybe even a pacifier with a little bit drops of Sweeties, which is that little sweet glucose that gets the baby to be calm so we can get an accurate reading. Because again, this doesn't work if the baby's crying. It doesn't give accurate oxygenation levels for, like I said, it's the upper and the lower extremity. And I just quickly put for you guys here how this works. The machine will tell you you need to have at least 95%. And that's easy to remember because it's just, we want to see that in adults, right? Our O2 sat 95% or higher. And then the important part about that, you're very often will get 100% with the babies, but it has to be at least 95. And then if you need to have less than or equal to a 3% difference between both of the readings to make sure that the heart is properly oxygenating the same throughout the body. And then this kind of just goes through, if you get a fail, then you have to reassess in an hour. And then if it's a bigger difference, like if the oxygenation, depending on the hospital, is an extremely low number, that would be an immediate referral to the NICU because there's a problem with the heart. Okay. So this is where we have to poke the baby. And I'm going to quickly tell you guys a technique. I hope that you get a chance to do this in the hospital because it's scary. You're worried about making a baby cry. But if you are able to learn the proper technique and do it, it is oftentimes the babies don't cry. You can get good bleeding. You can get it done quick. And it's not near as traumatic as it could have been. So quickly, I'm going to tell you, the baby is in their little crib. There is, you can lift it so the baby's elevated. You're either going to do this in the patient room or in the newborn nursery, depending on what your facility wants you to do. So you want to get that little heel in the dependent position. So you want to elevate the head. A lot of nurses don't do this, but I find that it makes a huge difference. Then what I do is you typically have one foot that you always do, and you get in the habit of using that same one and getting really good at this. So you swaddle the baby nice and really good, because you remember babies like to be swaddled in tight because that's how they just were in utero. They're not like us. They don't like that feeling of their being able to move. So we want to get them as comfortable as possible. So in this case, we swaddle them nice and firm, but we have one foot sticking out. So you do that. Then what I do is I roll the baby on their lateral side. So for me, I would roll the baby away from me, and then I would take another blanket and kind of secure the baby so they're on their lateral side. The heel is in the dependent position. Then they have these heel warmers where they're cool. You just kind of crack them like a glow stick, and they have this little sticker part that goes around so you can apply warmth to the area where you're going to poke the baby. So now we've got the heel in the dependent position. We've got the baby rolled over nice and comfortable, and we're getting the heel warm. I always have a pacifier ready, and I have Sweeties ready. in case the baby does fuss, I want to keep them nice and calm and comfortable. And if they're not calm already, that almost always does the trick. Okay, so then when you do the poke, like I said, it's not the same Accu-Chek poker that just goes in with a little sort of round hole. It has this sort of almost like slicing feature. So the big deal is you want to do the lateral sort of fleshy outside over here, never in here. And you want to do firm pressure. Most of us, we don't like to poke anybody, especially not a new baby. So we just kind of poke a little bit. The problem with that is then we don't get adequate bleeding, and it's horrible for the baby because it's taking longer. You don't have a good sort of slice, and you're having to squeeze it out because remember, you have to fill those 5 circles with blood. So my advice to you guys, if you get to do this, firmly press just one time against the baby, and you're going to get some good bleeding. Have your paper ready right away. You're comfortable. You have everything set up. They're on the side you want. You bring that paper and you gently just let the heel fill the circles. You don't have to do a lot of squeezing. You just kind of firmly hold from the top of the arch in the middle of the heel. Let it adequately fill. You don't have to squeeze, and then gently just put it down on the circle. This works so well. And the takeaway is being adequately prepared. Like I told you, get the baby in the right position, take the time to get your best blood flow, and then be ready. And that paper, they're crazy about that paper. Each circle has to be completely filled. You have to turn it over back and front to make sure that it's filled. But you only can actually apply the blood on one side, and you can't layer it. So don't get scared by that, but just go circle by circle, one at a time. Either side you want, you can do the blood, you just can't do both sides. Then when you do the first side, turn it over and make sure that it completely soaked through and filled the circle on the other side too. Otherwise, the state will send it back and it'll be a nightmare. And that's a big sort of mark against the hospital if you send it out and you don't do it right, because you poked a baby for no reason. They couldn't do the test and they're going to have to do it again. So I hope this helps you. I hope that you get a good amount of blood. And then when you're done, I put a little cotton ball, apply pressure to get the blood to stop bleeding. And then I kind of just tear it off and leave that little piece of cotton, tiny piece of it, just to sort of that clots the heel. And then I put a tiny little, you don't have to do any special wrap or anything, just one of those tiny circle Band-Aids on top of that little piece of cotton. And then you safely either bring the baby back from the nursery or point out to the parents they have this little Band-Aid because we were successfully able to perform this newborn panel. The baby has to be at least 24 hours old to do this. Older is better. You want to do it before discharge. Different hospitals have different policies, but it is required that the baby is at least 24 hours old. Okay. So we're going to go through this Ballard assessment. This is most reliable when the baby is between 30 and 42 hours of age. So this assessment is not, when I first heard of this, saw these charts, which I'm going to show you the chart right now. I thought this was when the baby first came out, like with the APGARs, that they were doing this whole assessment. But this is not a brand new baby when they're doing the assessment. And very often it's actually the pediatrician who does this. You just want to have an understanding, you may be tested on this and have a general understanding of what this chart means. And this is the scores that they get that sort of describe, this is very related to how mature the baby is, back to that SGA and LGA. Now, when I saw this chart, it was really hard for me to make sense of it and kind of like commit what this looks like for if I were to be tested and if they were to say to me, okay, arm recoil, what would you expect? Or what does this look like for this baby? So what I did for you guys is I kind of took a little piece from the chart and I showed you what they're looking at for the baby and what it looks like. And I'm hoping that this will help you just have a better understanding of what a real baby looks like with this Ballard scale and these little markings here. You don't have to go crazy with memorizing this because very often it's not even the nurses who do this, like I told you. But if you just maybe remember these pictures and you look at the baby and you can get a better assessment of what this looks like a 4 to me, what it looks like with these stick figures. You also, if you go to the Ballard site or if you look in your textbook, you can get a better appreciation of what this means for a baby. I'm not going to go into great detail with you here on that, but I am going to just go through each stick figure and show you what a real baby looks like. So here's the posture. Here's the square window. So again, you're comparing that to these pictures here. That's what a real baby's hand looked like. And you would just kind of make your assessment of which picture that looks like most, and then assign a score to the baby. Here's those stick figures. Here's the arm recoil here. And again, you can possibly use these pictures, my slides that I'm giving you, with the textbook if you want to know more of what each of these mean with the baby and how we assess how mature they are. This is a maturational scale is what it is. Here's a real baby, what this angle looks like here. So you can appreciate how this relates to a stick figure. Scarf sign, a real baby, where they're pulling the arm over across, and then you're assessing what that looks like compared to a real baby. Heel to ear measurement. This is what it actually looks like. Again, this would show if a baby's extremely sort of flaccid or flexible, or what we would expect as normal. This Ballard scale also measures the skin. And so this is more words than the picture like before, but you would expect some peeling and drying of the skin, but this also indicates how mature the baby is or what the gestational age of the baby is. This is that lanugo, that fine little hair on the baby, and same thing, that lets you know about the baby's maturation. So this is related to what it actually, you look at the baby's foot here and creases, and that is an indication of maturation as well. The breast assessment, so whether or not it's fully developed and you can see it or you can feel it, is another indicator of gestational age. Remember, talking about maturity and gestational age with this Ballard scale. Okay, so ears and eyes, that you're probably like, what is that? Well, that's an eye there, and that's an eye that's not opening at all. So this eye and ear is the same. So these are intimately related. So you would predict that the eyes would be the same maturational level as the ears. And so here's two examples of a low maturity level for the ears. And when you get over to this side, it would be thick cartilage and it would bounce back and it would look normal. But just again, showing you what they're talking about of, when there's fused lids, as opposed to, what a normal eye looks like. It's open. And even if it's endemic, it's normal because we, like I mentioned earlier, babies often have endemic eyes. Okay, so I showed you earlier the assessment of the genitalia for the boys and girls. This Ballard scale is related to maturation, again, to their gestational age and what you would predict. And just kind of goes on where you go to this side, again, it's more mature and this is less mature. I forgot to mention too that in the female assessment, there's something called either a vaginal tag or a hymenal tag. And you do chart that. And it's this kind of little piece of skin that's kind of right here. That is not necessarily related to gestational age, but I just wanted to bring it to your attention because it's considered normal. It's very common, and it's part of the charting that you do on the newborn assessment. And so again, you could point that out to the parents and just point out that that's very normal for a baby. And likely that's going to resolve and not be there forever, but it's just this kind of tiny extra little piece of skin right there. Okay, more adorable pictures. Okay, so these are neurological reflexes for a baby, and this is something that we do on the mother-baby floor. They're pretty self-explanatory and they're expected in babies. And also when you're talking to the parents, you can kind of explain to them why their baby might sort of like, whoops, be startled or doing that sort of thing, that it's normal, but it might look funny to them, especially if they've never had a baby before. So rooting is, you want every baby to have the rooting reflex, and that's where they kind of turn their head and they're sort of like bobbing with their mouth open because they're ready to feed. That's a sign that they're hungry, and it's also a reflex. And you want to feed the baby if they do that, but you kind of want to be more on top of that before they start rooting, and know that, hey, it's been 2 or 3 hours, depending if you're breast or bottle feeding. And this is a hunger cue right here, the rooting reflex. Sucking, this is part of our assessment of the baby. We would not put a bare hand in like that, but we would have a clean glove. And actually, I don't love this technique where the finger is this way. If you turn it upside down, and those of you who have your own babies or about to have babies, remember this too. This is a way to soothe the baby, because if you put your gloved hand in upside down, they're automatically going to suck. If you don't have a pacifier, or you don't have a breast or a bottle, and you want them to be calm, easy trick. It also is a way to make sure that baby has a suck reflex. You can palpate and feel to make sure that the upper palate is closed as well. You may be able to look further to see, like what we saw earlier, maybe there's some sort of tongue tie, or the frenum is really tight on the top. If baby's not sucking, they may have some sort of issues. They may be, their gestational age or their maturity is low, or maybe you might see a respiratory depressed, where there was a drug. We'll have like a heroin mom where the baby's not sucking, and if the baby doesn't suck, the baby can't eat, and if the baby can't eat, that's bad. So if they don't have a strong suck reflex, we look into it further and try to figure out why, and then figure out ways that we can help the baby get nutrients if they're not sucking, because that is huge, and we need to make sure that they can get intake. If the baby's not sucking at all and doesn't suck at all, they would go to the NICU. These are just kind of what some reflexes look like that the baby does. This straddle one and this tonic reflex, I just have pictures for you here. These are fun reflexes that you can show the parents too, where we're not doing this in the hospital, having them step, but this is cute when they get home. I suppose they may be, I probably wouldn't do this in the hospital, just because I wouldn't want the parents encouraging them to hold up the baby vertically in their room, but baby would do. It's almost like they're walking, little steps here. This one I love to show the parents, because most parents understand, like I said, when we're doing that CCHD testing, it's these reflexes that get in the way. So they understand if they put their finger in, that little fist will clamp on them, and that is a reflex that we know, that we assess and chart. But they often don't know that the toes do that too. So it's cute to kind of show, especially if mom's resting and dad's watching the newborn assessment, I'll be like, see, put your finger here, and they do that with their toes too, and it's just super cute, and they get a kick out of it. Okay, so this is talking about what I'm going to talk about next. This thermoregulation is a big deal, and like I mentioned in the very beginning of this, we are less worried about babies getting hot or fevers, and more worried about them being cold. So we're constantly making sure baby's swaddled appropriately, or skin to skin, and warm enough. Okay, so reiterating, we worry about moms being hot because we're worried about them having infections. So we're constantly taking their temperatures as well, although this lecture is about babies. But babies, we're taking their temperature often too, because we don't want them to be too cold. So I want you to know that there are certain risk factors or newborn characteristics that make them more prone to being cold. I have that here. Just the fact that they're a baby, they have 3 times more surface area related to their body mass than an adult. So they are more prone to being cold. And look at this too. Rate of heat loss is 4 times greater. So they get cold quick. We have them unwrapped or swaddled to weigh them. We want to get them wrapped up again or close to mom or dad quickly, because they lose heat fast, and we don't want a cold baby. This picture I got from your textbook, and it's just kind of a cool way. I was talking about how babies lose their heat fast. This kind of just shows how that happens. And I'm not going to read through all this, but just the 4 ways here. You learn this in your prerequisites back in physiology, I'm sure too, about how adults lose heat. And this is those same evaporation, conduction, convection, and radiation. And it just kind of explains nicely, I think, about how that works for a baby. And again, this came from your textbook if you want to read more about it. Okay, us as nurses, how do we care for a baby who's cold? 97.7 is the magic number. If the baby is lower than that, then we are going to start an intervention. They should already be dry. If they're not, like let's say that they spit up or they urinated and it's on their clothes, number one, we want to get them dry. We want to, this says swaddle first, but if I had a cold baby, I'm going to recommend skin to skin first with mom or dad. Swaddle would be the next best thing. If you come in and they're unwrapped, that's a reason that they might be cold. But if they're already swaddled and they're cold, then that's already been done. So we have to go on to the next things. Make sure they're dry, put the baby skin to skin. The last one would be the radiant warmer, like I told you earlier. And you'll see a lot of pictures online when I was trying to find good pictures for you guys where they have the baby in their clothes here. That's not a good idea. This one at least is an example of a baby being naked because like I said earlier, they've got tons of skin exposed for their body mass. And when we have this warmth coming down on them, we're not trying to warm the blanket or the clothes. We want to warm the skin and that baby. Baths are a hot topic. I'm going to just touch on this quickly. It used to be that baths were done earlier for babies. Now the paradigm shift is that sometimes many hospitals are saying unless there's some reason, we're not even going to bathe the baby in the hospital anymore because that gets them cold and we don't want babies to be cold. And in most cases, it's not medically necessary to give the baby a bath. Now, there are reasons. Just what I can think of right now would be if it was a MEC delivery, like if they have poop on them, or GBS positive, that's the group B strep, the beta strep, where we're worried about infection. So the risk for infection is outweighing the risk for being cold. But like I said, very often we are delaying or even avoiding the bath altogether now in the hospitals. It'll be interesting for you guys to see your clinical locations, how they're handling the newborn bath, and you could ask questions about that. Okay. So this is, if those of you who haven't had babies yet, or if you don't remember, I don't want you to be surprised by what the poop looks like. When I keep saying MEC delivery, which is short for meconium, when a baby's first born, they are excreting what's already in their gut, and it's this black tar sticky stuff. It's really hard to get off the baby's bottom and their skin because it sticks to them. And so you need to gently get it all off. We don't want to leave it on because then baby could get a rash. So we are in our teaching, especially for the new parents or parents forget, you'd be surprised. They may have older kids or they may haven't done this for a while. This is such a short period. Often we have an opportunity to re-educate them. This is normal. Meconium, we chart that it's a meconium. Again, we get them clean. Then breastfed babies have this yellow seedy appearance. So we want to, of their poop, it doesn't really even look like poop. It doesn't smell like poop. It smells like spoiled milk to me. And you kind of get a sense for that either as a parent and also as a nurse where I can walk in a room and I can smell this sour milk and I'll say the baby's diaper needs to be changed. And oftentimes parents will be like, no, they don't. I'm like, okay, well, I'm just going to quickly check for you. And I'm happy to change it for you if I see something. And my nose doesn't usually fail me. It's because I think parents are more in tune to that poop smell, but this is a sour milk smell. We chart as it changes, and this is good news because the baby's clearing out the meconium and intaking the colostrum from mom, and we are pleased that they are transitioning to this transitional or yellow stool. This is a formula-fed baby, or maybe supplementing with both breast milk and formula, and it smells a little bit more like poop, and it looks a little bit more like poop, but it's still not going to be like a bowel movement that you would see in an older child. So if you change, sometimes parents will have two different, they'll have a toddler still in diapers too. That's real poop, like human poop, smells like poop, looks like poop. Newborn poop, it doesn't look like real poop. And here's some pictures for you here. Pictures of diapers. I mentioned earlier that it is normal for a baby girl to pass a little bit of blood, like a period here, or sometimes you'll see it's called pink brick dust spots like this. This could be from a boy or a girl. Oh, pseudo menstruation, that's the word they use for this. It almost looks like a period for the baby. So as a nurse, you just want to reassure them that it's normal, we'll chart it, but don't be worried that your baby's bleeding. And that just happens with the hormonal changes. And this is just a typical old normal diaper. Most of the diapers are very absorbent now. So it used to be you kind of see a pool of urine. Um, so this is kind of what makes it hard when it's very important that we are keeping track of how many void and stool diapers that in our shift we keep track, and we ask the parents. It's very important for them to tell us. And that's why I was telling you that cool line that they have on a lot of the newborn diapers now, that the ones I've seen are yellow to start with, and then they turn blue if there's urine. And so even if it's absorbent, and because it's not going to be this heavy for a brand new baby, it lets us know, the nurses and the parents know, oh yeah, hey, we had a void here, so we track it. Okay, I wanted to go in a little bit more detail about jaundice for you guys because it's a big deal. So I have like 5 slides just to give you a preview. This is a picture of a baby that's under Billy Lights, and we want to have as much again, when we're trying to get them warm, or when we're trying to get this vast amount of skin exposed to lower the Billy levels, we don't want to have them in clothes here. So they're going to have as much, sometimes they don't even put a diaper on, or they just have a pad under. And we want to protect their eyes from the lights. There's different ways to do this. This is a cute picture I found, but babies' eyes are completely protected and can be damaged by the lights. Okay, so I just want to do a quick teaching again, because jaundice is a big deal. And like I said, we as adults, if we have a normal functioning liver, then we're not going to have any bilirubin in our blood. And the reason that we're monitoring this so closely for babies is they have an immature liver, and they're not able to adequately oftentimes excrete that out. So we may need to do an intervention, and we want to keep a very close look at that. And like I said, we're first looking at what their skin color looks like. You can tell often when a baby starts to get yellow. It's not right when they're born, but if you see that, you may do a spot check with that TCB. Again, that stands for transcutaneous bilirubin check, or the protocol is typically at 24 hours and 36 hours. So this is just a little understanding of that. And when you are teaching the parents, you're letting them know that just because their baby may show signs of elevated bilirubin, it doesn't mean they're going to actually get jaundice, but we want to be on top of that quickly. And oftentimes the first intervention, and that's why we're keeping such good track of their I&O, how often they're feeding and how often they're voiding and stooling. If it's just breastfeeding and we're seeing high levels of bilirubin, then and we're not seeing, let's say that we're not seeing a high level of voiding and stooling, this is when the pediatrician may strongly recommend that mom supplement with formula. Now, this may not go over well for some parents, where they're very, they had a plan, they were going to breastfeed their babies. And this is that whole psychosocial thing where we are adequately educating and caring for the needs of the parents who had this plan, but also teaching them that we need more output from baby to get that bilirubin out. So this tells you quickly about reasons that bilirubin may be higher in babies, and there are inherited diseases. Also, I mentioned earlier, when we do the cord blood, we want to know if mom's negative and baby's positive. That's where we do the whole RhoGAM, and we're worried about compatibility. But also a higher risk factor for jaundice is if mom has O blood and baby has any, so it could be O positive or O negative, and baby has a different blood type, any other blood type. And the way that would happen is if dad has a different blood type. So if, for example, you're getting a report that mom is O positive, which normally you're not worried about incompatibility there, but baby is AB positive or negative and Coombs positive, we are more on the lookout and alert that this baby is more at risk to develop high Billy levels and jaundice. This is that chart that I was telling you about. So when you're when you're a nurse and you do that TCB, we physically have this chart and one on the computer. You go to 24 hours and see. So if you are on this case, they're saying that, like, that's what I mentioned too. So if you're at 8 or higher at 24 hours, we would plot a circle here and we would draw a serum. And then you go back at 36 hours. And if you're at 12 or higher, you're high risk too. This old school thing is still done in hospitals, and it's a very quick and easy way to just look at that little TCB, non-invasive, and where should this baby be? And this I've seen that stays in the baby's paper chart. Okay, so this is good education for the parents too, because let's say the baby passes and we say, oh, maybe it was moderate risk or just makes it, or it's fine when the baby leaves the hospital. At discharge, we are still teaching the parents that they need to monitor for jaundice. And this just gives some ways where you can do it. You are like one, when you can just press your finger on the baby. And so if it's jaundice, it'll appear yellow. And then when you when the finger is removed, you can kind of see that color. This is just a little bit more teaching to understand about jaundice even after you leave the hospital. There was a thing called breastfeeding jaundice. I think your textbook still talks about it. It's a condition that is unknown. There's not much known about it. It's very unclear in all the data. So breastfeeding jaundice, I'm not going to specifically address in this lecture, but what I wanted to bring to your attention again is that sometimes jaundice will be seen in breastfeeding babies based on what I was telling you before about not enough. These paragraphs are just saying not enough is coming in. So there's enough coming in for the baby to be healthy and maybe be at the right weight. But if this baby is at risk for jaundice and high Billy, they, with breastfeeding alone, may not get enough input to provide enough output, which is the important thing, because it's the output that excretes all that Billy. And once we get all that out and baby's liver has a few more days, weeks to mature, then we're not worried anymore. So that's what I'm addressing here, and not this other phenomenon called breastfeeding jaundice, which, like I said, is the research is kind of sketchy on, and if you want to read more about it, you can find it in your textbook. Okay, so the other thing that is addressed in your textbook is pathologic versus physiologic jaundice. And so this is physiologic is considered normal and pathologic is considered abnormal, what I have here. So this is related to different disorders. And this is related to, just like the word I was, transient hyperbilirubinemia, which means that Billy levels, I keep talking about how changing Billy levels is what those big words mean. And your textbook does distinguish. So they call physiologic normal jaundice and pathologic, where there's a reason, where there's some sort of pathology and some sort of disorder, which may be leading to this. And that is an important distinction. And they're able to, this is not the common one, and they're able to pretty quickly ascertain if that's going on, and that baby would be in the NICU. Okay, my last slide related to jaundice. It used to be called kernicterus, and I think your textbook might still call it that, but it is this is the new longer word. So this is more serious jaundice. This is a related to something bigger that's going on, and I just kind of put for you the range of reasons that they may have this chronic bilirubin encephalopathy, and this is where the phototherapy, which is those lights that I told you about, they may actually have to have a blood, a transfusion exchange where they can get transfused with blood that doesn't have the high Billy levels. And this old thing that used to be called kernicterus, that is now this, is a medical emergency. A baby's in the NICU. And like I said, if they don't get the results they need quickly with phototherapy, this would be the case where you would do a blood transfusion. Okay. We're getting in the home stretch, guys, almost done. I mentioned to you that part of our teaching is to reassure the parents that babies lose weight. We expect it. Um, could be related to a fluid shift. It could be hormones. It could be all different things. And we reassure them, but we also, like I mentioned before, we closely monitor INO and we weigh babies at least Q shift. And typically in the hospital, so I've got the percentages here for you. I know in our hospital, we would, they, because this weight is so important on your baby's electronical chart, it'll say gestational age and it will say what their weight is. And then when you input the new weight that you do Q shift, next to that initial weight, it'll say percentage of weight loss. So when you put in those grams, like I told you, you get on the scale right here, then you kindly tell the parents how that translates to pounds. When you input those grams in the electronic record, it will calculate the percentage weight loss. If it's 10% or more, you want to call the pediatrician and let them know, because they want to take a look at why baby's losing more weight than it's expected. So 10% is kind of the magic number that you don't want the babies to lose. And if you get a chance, do this. It's pretty simple. You'll put one of these chucks on to zero out the scale with the chuck on, or and then you'll take off the baby's clothes. You do this quick because remember we talked about earlier, baby gets cold very quick. And I wouldn't do any other assessments while baby's naked on here. I'd want to get baby back warm quickly before doing additional assessments. And they don't like to be naked and they don't like their arms being able to flail. So they often cry during this and we want to get it done quick. This is something, if you're interested, that's kind of cool, that talks about why could baby, this is what a pediatrician would do, so don't go crazy with this. But like I mentioned, when you give them that call that baby's lost 10% or more of their weight, they are looking at this big chart they go through. It's like an algorithm. It is an algorithm. And they try to figure out what is going on to make the baby lose this weight. So I know, like I said, don't stress about this. I got this from UpToDate, which is an amazing resource. It's very current, tells you current practices, because I wonder, like, well, so what do they do when I call and I say, baby's lost 10% or weight, or no, like how do they even know what to do next? And it's kind of, I don't know, just to glance at this algorithm and see what a neonatologist or pediatrician would do next to problem solve why they're losing more weight than what's considered normal. Okay, so I have 2 slides on respiratory distress here for you. And you just want to be able to quickly recognize, like I said in the beginning of this lecture, what's considered a normal newborn and what's considered not normal. So anything that indicates respiratory distress, like I told you about the retractions in the chest, any kind of nasal flaring, use of accessory muscles, grunting. And the term they use in the hospital is, they say the baby's singing, like, so that they're kind of making a noise. When I first got there, I was like, oh, how cute, the baby's singing. Somebody looked at me funny. I thought, oh, that means grunting. So you may hear that in the hospital too, noises while they're in their respiratory effort. And then of course, cyanosis, that's where they turn blue and you worry about oxygenation. So this is just to remind you that these are any signs of increased respiratory effort you want to be aware of, and that's not considered normal. These are interventions. So when a baby is when the baby's new, you guys learned this probably in a different unit. I just wanted to reiterate so you get the baby on mother baby, you could look at the chart and see what interventions might have already been done if they've previously recognized either risk for or respiratory distress. And you may see in the chart that some sort of corticosteroids were administered to the baby right away after they were born to help the lung maturity. And that's related to the surfactant. Remember, so if a baby is immature or young, they has to be delivered early when they didn't really want to. They have decreased levels of surfactant, and so that makes it so it's harder for them to adjust to their lungs breathing instead of getting their oxygenation through the placenta. So that you may see in the chart. And then these are after the baby's born, when likely a baby with any significant respiratory expert is going to the NICU, because again, it's the normal babies that stay on the mother baby unit, because those nurses have 8 patients they're taking care of. They are not able to care for adequately a baby who's in this kind of distress. And then this is very important to closely monitor. Again, this is more in the NICU situation, but we're always we want to keep these babies warm, and they're very careful with fluid management and nutrition for any kind of baby in respiratory distress. So the reason I have these 2 slides, again, to reiterate, is being able to recognize signs and symptoms quickly of what's not normal in a baby breathing. And then also when you look back at the chart, being able to go, oh, they were administered some sort of corticosteroids. I might be alert that this baby could be at risk for some sort of respiratory issues. Almost done, guys. Let's see. We have 79 and we're on 75. I hope that you guys are enjoying this and it's not seeming too long. When you are caring for the newborn, you may have a newborn circumcision, which is the most common surgical procedure in the US today, which blew me away. However, during these COVID times, in some hospitals, this may be considered elective, and you may not be seeing it as often in the hospital. Different pediatricians do it different ways. Some of them don't do it at all. Some of them want to do it in their office for a follow-up. And the other issue is, depending on the facility where you work in the hospital, this very often isn't covered by insurance. So that may be another reason that parents would elect to have this later in the office, or maybe it's not covered by government insurance at all. So that would be another socioeconomic consideration about why different cultures or socioeconomic status may be circumcising their newborns or not. And so you just want to have an awareness of this and be considerate in your nursing when parents are asking you questions or making decisions whether or not they're going to circumcise their baby. This is a big deal if they do it in the hospital, where you as a nurse want to teach the care and enact the care yourself. I'm not going into, you got in your skills day, I think that there's 3 different ways they can do a circumcision. Very often it varies on experience, on what type of doctor is, whether it's a surgeon or whether it's an OBGYN or pediatrician. There are 3 ways, but for the nursing care, they're typically they're going to come back with a little petroleum jelly, and you're going to just keep it nice and clean, put the jelly on and apply the gauze dressing. This is what it looks like when you go in the nursery. You'll see the person who is performing the surgery, and then this is the nurse next to him. Some facilities will let dad come in too. Typically, if they ask my advice, I would say there's not a reason for them really to go very often. So they may or may not give a lidocaine shot. Some doctors do. That's a local anesthetic. Some of them say that they think the shot hurts more than the procedure. That surprises me, but almost always they'll have sweeties. And again, it's typically a little like purple plastic container, and you break it off and you drop this little sweet stuff in the newborn's mouth, and then you give them a little pacifier, or you put it on the pacifier, and it just kind of relaxes them. One doctor told me before that those sweeties have the same effect on a newborn's brain as morphine does on an adult, and it just sort of like chills them and numbs them. So I don't know, I haven't actually looked at the pathophysiology of that, but I will tell you it does seem to chill and numb them. So it's a nice intervention in coupling with the lidocaine, I think is probably what I would consider the ideal situation. It's for when you first time you see it, this is just a closer look of this restraint. The baby has to be strapped down, and you see them exposed here, and they're really vulnerable. And as a nurse, it's hard to see that, and you really want to make them comfortable, and especially if there's not parents there. The doctors, in my opinion, seem to be very matter of fact about it, and sometimes there'll be extra bleeding and they'll cauterize it, or they'll put this like silver nitrate stuff on it. And it's very matter of fact. And us as a nurse, I feel like it's a good opportunity just to give that newborn like attention and care like you would hope that somebody would if that were your newborn. I mentioned that babies' baths are changing in the hospital. So that just really depends on your facility. But when you are educating the parents, you want to let them know that they don't completely submerge the baby until that newborn little umbilical stump has fallen off. It usually is off by 2 weeks at the most. Um, Also, you want to teach the parents that while they're there at the hospital, stay, and when even after we take that little clamp off, like I showed you earlier, they want to fold the diaper away, down away, and so it's not up and irritating the umbilicus on there. You can, people say, do I fold it down or do I fold it out? It doesn't matter, whatever's comfortable. Typically in the hospital, we fold it out and then we just tape around. Okay, 2 more slides, guys. This is a good example of what a chart looks like for, you might give this to the patient or the nurse might have something like this. It may be electronic. You may give it to the patient and then you electronically put this on. We keep very close records of, like I said, the breastfeeding left and right. We would say how many minutes. We would keep track of the pump, and then this isn't typically on this, but if you did, you would say how long they pumped, and then you would do the intake of the bottle from the breast milk. You keep track of the void in the stool, like I told you, and you want to have all the times here because breastfeeding, the recommendation is every 2 hours. And so unlike most night shift nursing, where you might think, oh, you get a break, your patient's going to sleep, it's actually the contrary here. You're waking up this poor sleeping mom because it's your responsibility to keep track that that baby's getting some kind of feeding, if breastfeeding every 2 hours and bottle feeding every 3 hours. And so that takes some teaching too, because oftentimes the parent, they're always exhausted and they want to sleep and they say baby's sleeping. And so you have to let them know about how that whole thing, how they lose weight. We want to establish patterns. We want to establish the milk supply. And unfortunately, even if the baby's asleep, they don't know they need to wake up, and we need to wake them up and feed them. I mentioned earlier how you fold the diaper away from the cord here. This is just a reiterization. You shouldn't see any purulent drainage or any bleeding. You should see it drying. We don't take off this clamp until it's completely dry. If that were still wet, we would keep this clamp on. And again, I told you it's just a little quick tool that you use here, and then we give that to the parents. This is a final summation slide, and this is just sort of letting you know about the ongoing nursing care for a newborn. And again, we are assessing the vital signs, which don't include blood pressure with a normal newborn. If the mom is GBS positive or unknown, we're more worried about infection for the baby, and this can lead to very serious conditions. And so typically, if let's say vital signs for the normal newborn are Q6, they now are Q4 if there's any risk for infection, including if the mom was GBS positive. We are throughout the shift doing this here. We do a full newborn assessment every shift. Some hospitals do it twice a shift. So they do a complete one and then so there's 2 ways to approach it. You do an absolute full system assessment at the beginning of your shift. Then you could do sort of pieces of the systems throughout the night or the day when you're with a newborn, or you could just do quick assessments and vital signs and then chart a complete assessment again at the end of your shift. That depends on the facility, but newborns can change quickly, and it's very important that we document if things are changing. Like I told you about the weight here, and I mentioned earlier, the vaccines. We want to encourage, if not insist, moms to feed the babies every 2 to 3 hours. And then, like I said, keep everything dry. And once the baby's stable, if that's your hospital policy, then you can give the baby a bath. Hope you guys have enjoyed this. I know there's a lot of information here. Hopefully, when I send you this PowerPoint, you can use it as support or your textbook and your lectures from Professor Nicola. Best of luck on this exam and your nursing careers. And I hope to see you guys again soon.